We begin with the concept of decline, specifically the failure of memory. Our first case, case 1, features a 73-year-old woman presenting with classic progressive short-term memory loss.
Okay.
She loses library books, she forgets recent conversations, she leaves the stove on, but, and this is the key, she can still recall vividly stories from her childhood and her wedding day.
This selective pattern of cognitive failure is the quintessential presentation of Alzheimer's disease. It's a progressive disease, and that clinical finding short-term memory loss while long-term memory is initially preserved is just so consistent with the primary sites of pathological damage.
Okay, so let's unpack this conceptually. When we look at the brain of an Alzheimer's patient, what are the primary structural changes that are actually driving this decline?
Well, at the macroscopic level, the big picture, we see profound cerebral atrophy. The brain is physically shrinking, particularly in the frontal, temporal, and parietal regions.
Just wasting away.
Exactly. But the real story is microscopic. There are two pathological hallmarks: the extracellular amyloid plaques and the intracellular neurofibrillary tangles.
Right, plaques and tangles.
It's toxic to the neurons. This plaque buildup disrupts cell communication, and eventually, it leads to neuronal death, causing those cognitive symptoms we see.
The insight here is really driven by genetics, especially when we look at specific risk factors. Advanced age is the biggest one, of course, but 3 genes tell us almost everything about the pathology. Let's start with the one that provides the biggest conceptual aha moment: amyloid precursor protein, or APP.
This is such a critical link. The gene for ATP is located on chromosome 21.
Okay.
So if you think about conditions that involve trisomy 21, namely Down syndrome patients have 3 copies of that chromosome.
An extra copy.
An extra copy, meaning they have an increased dosage of the APP gene. This is precisely why individuals with Down syndrome almost universally develop Alzheimer's symptoms, and they develop them severely early, often between 30 and 40 years of age. It just powerfully demonstrates that the dosage of APP directly correlates with the disease onset and progression.
That's incredible. It immediately links the specific protein accumulation back to a specific genetic overdose. So what are the other 2 key genes we need to know?
Okay, so we have presenilin 1 on chromosome 14 and presenilin 2 on chromosome 1. Mutations in these are primarily associated with the rarer, more aggressive, early onset familial forms of Alzheimer's.
And what do they do?
Both are involved in the process that actually chops up the APP into those pathological beta amyloid fragments. They're part of the machinery that creates the problem.
And the last one.
Finally, there is epolipoprotein E, or ApoE, specifically the epsilon-4 allele. This is the major genetic risk factor for the much more common late-onset sporadic form of the disease. It significantly increases the risk and often lowers the age of onset.
So we have shrinking tissue and these accumulating junk proteins. What is the fundamental chemical breakdown we are trying to fight when we look at treatment? What's going on at the synaptic level?
The primary biochemical deficit is the preferential loss of acetylcholine, or ADOC, and the enzyme responsible for making it, choline acetyltransferase. And this loss is most profound in the cerebral cortex and the hippocampus, the very areas that are essential for memory formation. Essentially, the parts of the brain critical for forming new memories are starving because they are losing their primary chemical messenger, acetylcholine. Is like the electrical wiring is frayed in the memory center.
Which perfectly defines the treatment strategy then.
Exactly. The initial treatment is aimed at boosting that deficient signal. We use acetylcholinesterase inhibitors drugs you may have heard of, like donepezil, rivastigmine, and galantamine.
Right.
They block the enzyme that breaks down acetylcholine, thereby preserving what little aethete is available in the synapse, hopefully improving transmission.
And what about the other class of drugs?
The secondary treatment addresses another issue: the excitotoxicity caused by excessive glutamate signaling. Here, we use NMDA receptor antagonists, like memantine, to block that excitotoxic effect, protecting the neurons from being, well, overstimulated to death.
So we've seen Alzheimer's as a protein clearance and a cholinergic issue. Now in case 14, we see the same principle, a toxic protein building up. But this time, it hits a different, very specific target in the basal ganglia, causing a movement disorder.
Okay.
This is a 39-year-old man suffering from uncontrollable dance-like movements known as chorea, coupled with early onset dementia. And the family history is key. His father died young from very similar symptoms.
This clinical picture, the chorea, the early dementia, and that strong autosomal dominant inheritance, It points immediately to Huntington disease. It's a
Hmm.
devastating inherited condition, and the strong family history and early presentation are immediate red flags for a highly penetrant genetic defect.
The genetic root here is unique. It's one of their trinucleotide repeat expansion disorders. Can you unpack that for us?
It is.
Yeah.
So Huntington's is autosomal dominant, located on chromosome 4. The mutation is the expansion of the trinucleotide CAG repeat. CAG, 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 over and over. This repetition codes for the amino acid glutamine, and when it's repeated excessively, it produces a dysfunctional protein that gradually and selectively destroys very specific parts of the brain.
And what are those specific parts, and why does their loss cause this wild, uncontrolled movement?
The hallmark neuropathology of Huntington's is profound atrophy and neuronal loss in the caudate and the putamen.
Okay, the striatum.
Together, those two structures form the striatum, which is a key component of the basal ganglia motor control loop. Specifically, we see a degeneration and loss of the GABA aminobutyric acid and cholinergic inhibitory neurons.
So you're losing the off switch.
You are losing the brakes. Because the striatum's inhibitory brake is damaged, the thalamus becomes excessively active, and that leads to the uncontrolled, involuntary, hyperkinetic movements we call chorea.
The prognosis is closely tied to those repeats. Let's expand on the concept of anticipation in this context, because it's a terrifying genetic mechanism.
It really is. Anticipation is a phenomenon we see in trinucleotide repeat disorders, where the disease manifests at an earlier age and often with increased severity in successive generations.
Why does that happen?
It happens because the trinucleotide repeats, the CAG in this case, tend to further expand during meiosis, especially when they're passed on by the father. So the patient's father may have had, say, 45 repeats leading to death at age 45, but the patient himself may have 55 or 60 repeats, causing his symptoms to start much, much earlier.
And as a quick knowledge bridge, we should note that this unstable genetic mechanism, these trinucleotide repeats, isn't exclusive to Huntington's.
No, not at all. It's a signature of several major neurological diseases, even though the specific repeat and the location are different. We see it in Fragile X syndrome, which has a CGG repeat, myotonic dystrophy with the CTG repeat, and several types of spinocerebellar ataxia. It's a remarkable kind of parallel pathology, showing just how fragile the genome is to these repetitive sequences.
From movement run wild, let's shift to movement suppressed in case 26, Parkinson's disease. We have a 66-year-old patient who notices a new onset tremor in his right hand, difficulty walking, a shuffling, hesitant gait, and his friends notice his face seems blank. He doesn't react much anymore.
This is the textbook clinical picture of Parkinson's disease. We often define it using the mnemonic T-trap.
Trap.
T for tremor, classically a resting tremor. R for rigidity, a cogwheel rigidity. A for akinesia or bradykinesia, which is slowness and difficulty initiating movement. And P for postural instability.
And all those other associated features, the masked faces, the shuffling gait.
They're all part of the syndrome, yes. The changes in mood or affect are very common too.
So structurally, where's the problem? What's breaking down?
The core neuropathologic finding is significant neuronal loss in the substantia nigra pars compacta. These are the neurons responsible for producing dopamine. Their death leads to a profound decrease in dopamine input into the basal ganglia.
And we look under a microscope.
Histologically, we look for eosinophilic cytoplasmic inclusions in the remaining neurons. These are characteristic of the disease, and they're called Lewy bodies.
Okay. Understanding the functional anatomy of the basal ganglia and how dopamine loss causes bradykinesia is one of the biggest conceptual puzzles in neurology. Let's spend some time on this because it clarifies the why of the symptoms. Can you break down the direct versus indirect pathways for us in simple terms?
Absolutely. Think of the basal ganglia as a complex volume control or mixer for movement. It has two competing circuits that must be perfectly balanced to get smooth, voluntary motion.
Okay, let's start with the direct pathway. What does it do?
The direct pathway acts like the gas pedal. When activated, its job is to facilitate movement, and dopamine stimulates this pathway via its D1 receptors. So in a healthy brain, dopamine hits D1 and tells the basal ganglia, go, start the movement.
Simple enough. Gas pedal. What about the indirect pathway?
The indirect pathway acts like the brake. Its job is to suppress or prevent unwanted movement. And crucially, dopamine inhibits this pathway via its D2 receptors. So when dopamine hits D2, it tells the brake, stay off, don't suppress movement.
Okay, so here's the key insight then. When dopamine-producing neurons die in Parkinson's disease, the system fails in two ways at the same time.
Exactly. The loss of dopamine causes a dual system failure. First, we lose the D1-mediated stimulation of the direct pathway. That's the less gas pedal problem. Movement is harder to start.
And second,
And second, and equally important, we lose the D2-mediated inhibition of the indirect pathway. This means the brake is constantly stuck on. The indirect pathway becomes overactive, leading to excessive suppression of the thalamus, which reduces the movement signal going to the motor cortex.
so the resulting bradykinesia isn't just slowness, it's a profound systemic failure of both the starting mechanism and the braking release. It's an inability to get going and an inability to stop stopping.
That's a perfect way to put it. It is the inability to both initiate and execute movement because the entire system is being overbraked. And this level of understanding helps us conceptualize the treatment.
Which is to try and restore that dopamine balance. We use carbidopa-levodopa or Sinemet. We know levodopa crosses the blood-brain barrier, but what is carbidopa's specific role? Why do we need it?
Carbidopa is absolutely essential for minimizing side effects and maximizing CNS efficacy. Levodopa is the dopamine precursor, and it needs to reach the brain. If we gave levodopa alone, a lot of it would be converted into dopamine peripherally outside the CNS by an enzyme called dopa decarboxylase.
And that causes problems.
Big problems. That peripheral conversion causes significant side effects like nausea and vomiting. So carbidopa is a peripheral dopa decarboxylase inhibitor. It blocks that conversion outside the CNS, ensuring more levodopa actually reaches the brain before it's converted into the necessary dopamine.
And we must always remember that not every set of TRAP symptoms is true idiopathic Parkinson's.
That's vital for differential diagnosis. Certain typical antipsychotic agents are strong antidopaminergic drugs. They block dopamine receptors entirely and can induce iatrogenic or medication-induced Parkinson-like symptoms.
Right.
Similarly, some toxins, like MPTP, can selectively destroy the substantia nigra neurons, perfectly mimicking the disease. So we must always check the medication and exposure history.
Our final case in the degenerative section, case 38, brings us back to cognitive decline, but with a crucial difference. This is a 72-year-old patient with multiple risk factors, a history of stroke, diabetes, hypertension, and his cognitive decline is described as stepwise.
Ah, that word.
And it's accompanied by clear personality changes and difficulty speaking.
That phrase, stepwise decline, is the absolute conceptual differentiator here. It leads us directly to vascular dementia, or multi-infarct dementia, and it's the second most common cause of dementia after Alzheimer's.
And the pathology is totally different.
Totally different. It's rooted in chronic atherosclerotic disease, small vessel disease, or recurrent scattered microinfarctions, particularly damaging the white matter and subcortical regions.
So unlike the smooth, slow, gradual slide of Alzheimer's, here, every small, silent stroke causes an acute injury, resulting in a sudden, noticeable drop in function. And that leads to that characteristic scare-step pattern on a graph of their function over time.
Precisely. It is a series of small catastrophes that lead to a cumulative deficit. And an MRI, particularly a T2-weighted scan, will often confirm this by showing numerous hyperintensities, lesions in the deep white matter of the periventricular regions and the corona radiata, indicating previous ischemic damage.
Before we move on, we have to leverage this case to reiterate the critical differentiation process. When diagnosing dementia, we absolutely have to rule out the reversible causes.
This is a matter of profound clinical importance because for these, treatment can be curative. Irreversible causes include those we discussed: Alzheimer's, multi-infarct, dementia with Lewy bodies.
But the reversible ones?
The reversible causes demand investigation. A chronic subdural hematoma, normal pressure hydrocephalus or NPH, severe depression, which can often be called pseudodementia, and systemic issues like B12 deficiency, syphilis, and thyroid disease. You can't stop Alzheimer's, but you can certainly cure NPH with a shunt or reverse dementia caused by low B12.
It's a tragedy if you miss one of those.
Yeah.
And we must also quickly contrast chronic dementia with acute delirium.
Yes. Delirium is fundamentally different. Delirium is acute in onset. It often fluctuates in mental status. It involves profound inattention, disorganized thinking, and often hallucinations.
Right.
It's usually a sign of an acute medical crisis. Sepsis, intoxication, dehydration, a metabolic derangement. Dementia is chronic, progressive, and generally spares the level of consciousness until very late. You can't have delirium without also having an underlying medical issue that needs immediate attention.
Moving from the generalized decline of the cortex to incredibly precise localization, Section 2 is all about using symptoms as an anatomical map. We want to find the exact spot of the lesion in the spinal cord and peripheral nerves.
This is my favorite part of neurology.
It's fantastic. We begin with a textbook example. Case 2. Brown-Séquard syndrome. A 35-year-old construction worker with a piece of metal lodged in his back. He shows ipsilateral spastic paralysis and loss of vibration, but contralateral loss of pain and temperature sensation.
This constellation of signs is so specific that it gives us a satisfying, immediate diagnosis. Brown-Séquard syndrome, caused by the hemisection, or damage to exactly one half of the spinal cord. And based on the level of sensory loss near the navel, the umbilicus, we can estimate the injuries as right around the T10 level.
This case is the ultimate anatomical test because the three major tracts involved all cross at three different places. So let's trace them. Start with the ipsilateral deficits, the same side as the injury.
Okay. On the side of the injury, we see two major functional losses. First, motor function. Ipsilateral spastic paralysis below the lesion. This is due to damage to the lateral corticospinal tract. Since these motor fibers crossed high up in the brainstem, in the pyramids of the medulla, any damage below that crossing results in upper motor neuron, or UMN, signs spasticity, hyperreflexia on the same side as the lesion.
What about the loss of proprioception and vibration? Also on the same side.
That's the dorsal columns. These fibers carry position and vibration sense. They ascend all the way up the spinal cord on the same side of the body and don't cross until they synapse way up in the medulla. Therefore, damage to the dorsal columns at T10 causes ipsilateral loss of vibration and position sensation below the level of the injury.
Okay, that covers the same side symptoms. Now for the twist. The contralateral, or opposite side, loss of pain and temperature.
This is due to damage to the spinothalamic tract. This tract carries pain and temperature information, and crucially, these sensory fibers cross almost immediately within one or two segments of entering the spinal cord via the anterior commissure.
So they cross low down.
Right away. So when the left half of the spinal cord is cut at T10, the right spinothalamic fibers, which crossed over from the right side of the body a segment or two below, are damaged. This results in the loss of pain and temperature sensation on the opposite side of the body, starting a couple of levels below the lesion.
That contralateral crossing is just brilliant. It almost feels like the spinal cord designed itself to make localization easy for medical students, giving us this perfect internal map. It proves that the symptoms truly are the map.
It really does. And we can add another layer of complexity. What if this lesion were higher, say above T1?
Then you'd involve the sympathetic nervous system.
Exactly. The descending sympathetic fibers run laterally in the spinal cord. If a hemisection occurred above T1, we would likely see an ipsilateral Horner syndrome characterized by the triad of ptosis, a droopy eyelid, miosis, a constricted pupil, and anhidrosis, decreased sweating on the face. A single sharp injury can reveal damage to multiple ascending and descending systems all at once.
Okay, let's look at case 3, amyotrophic lateral sclerosis, or ALS. A 38-year-old man with progressive weakness in his hands and feet. He's having difficulty gripping things, he's tripping, and he has constant muscle cramps and spasms.
ALS is defined by the core tragedy that it attacks both the upper motor neurons, the UMNs, and the lower motor neurons, the LMNs, simultaneously. It's a progressive neurodegenerative disorder leading to total paralysis. This simultaneous involvement is the hallmark that distinguishes ALS from nearly all other neuromuscular diseases, which usually affect only one or the other.
Can you break down that paradoxical mix of signs this patient would exhibit? It seems contradictory.
It does. On one hand, you have the LMN signs, which are caused by damage to the anterior horn cells in the spinal cord. These present as muscle atrophy or wasting, profound weakness, and those visible muscle twitches called fasciculations. These are the signs of a floppy, wasted muscle. On the other hand, because the descending lateral corticospinal tracts, the UMNs, are also damaged, you see the UMN signs. Hyperreflexia, so exaggerated reflexes, increased muscle tone or spasticity, and a positive Babinski sign.
So the patient literally has the weakness and wasting of an LMN disease, but the stiffness and exaggerated reflexes of a UMN disease, sometimes in the very same limb.
Precisely. This paradoxical mixture of stiffness and wasting, often coexisting, defines the tragedy and the diagnosis of ALS. The progression is unfortunately relentless. Death is usually within 3 to 5 years, primarily due to neuromuscular respiratory failure.
And management is mostly supportive, with just one drug aimed at marginally slowing the progression.
Yes, riluzole is the only drug that's been demonstrated to extend survival, although minimally by about 2 to 3 months. It is thought to work by blocking glutamatergic transmission in the central nervous system, trying to reduce excitotoxicity to the remaining motor neurons.
Case 5 gives us central cord syndrome. A 70-year-old patient with rheumatoid arthritis suffers neck pain and weakness after a minor car accident.
Ugh.
And here's the key finding: hyperreflexia, but with much greater weakness in the upper extremities than the lower ones.
This is a classic central cord syndrome. It is the most common form of incomplete spinal cord injury, and it frequently occurs in older patients with pre-existing cervical spondylosis or arthritis who suffer a hyperextension trauma, like a whiplash injury. The damage is focused in the central watershed zone of the spinal cord.
Why are the arms affected so much more than the legs? That seems counterintuitive.
It relates directly to the somatotopic organization of the corticospinal tracts. It's like a map inside the cord. The tracts controlling the upper extremities run more medially closer to the center of the spinal cord cross-section, while the tracts controlling the lower extremities are positioned more peripherally, more to the outside.
So a central injury gets the arm fibers first.
Exactly. Trauma focused on the central canal affects those medial arm fibers disproportionately and first.
Let's briefly discuss that vulnerable watershed zone and the blood supply. Why is the center so vulnerable?
The spinal cord's vasculature is a bit asymmetrical. There's a single anterior spinal artery that supplies the anterior two-thirds of the cord, so the motor and pain temp tracts, and then there are two posterior spinal arteries that supply the posterior third, the dorsal columns. Watershed zones are areas between these major supplies, making them highly susceptible to infarction during drops in blood pressure, or in this case, direct trauma that causes swelling or compression in the center.
The finding of hyperreflexia indicates UMN damage below the lesion, but we also often see diminished reflexes right at the level of the injury. Why that local contradiction?
That's the subtlety of spinal trauma. While the descending corticospinal tracts, the UMNs, are damaged, causing hyperreflexia below the site of the lesion, the anterior horn cells, the LMNs, at the exact level of the trauma, say C5, C6, C7 roots, are also directly crushed or damaged by that central compression.
And LMN damage causes.
LMN damage results in hyperreflexia or no reflex at all. So you might see diminished biceps reflexes, which are C5, C6, right at the injury site, alongside UMN hyperreflexia in the rest of the body below C7.
Now, pivoting entirely from the CNS to the very edge of the system, Case 8 presents a focused peripheral nerve localization challenge, femoral neuropathy. A 72-year-old woman falls, develops a hematoma near her inguinal ligament, and now has severe weakness in her quadriceps and hip flexors, an abolished patellar reflex, but preserved leg abduction and adduction.
This is highly localized to the femoral nerve, which arises from L2, L3, and L4. This nerve innervates the quadriceps, which are responsible for knee extension, and the hip flexors responsible for lifting the leg.
Right.
Its compression, likely due to the trauma and the resulting hematoma under the inguinal ligament, caused these specific motor losses. And the abolished patellar reflex, which is an L2, L4 reflex, confirms that the lesion is peripheral, involving the nerve or the nerve roots themselves.
How does this specific location affect sensation? Where would she feel numb?
The femoral nerve supplies the skin over the anterior and medial thigh, and a specific cutaneous branch, the saphenous nerve, provides sensation down the medial side of the leg and the big toe. Any deficit in these areas would confirm femoral nerve involvement.
Now, for the key differentiator here, the thing that really pins the diagnosis, the adductor muscles are spared. She can still squeeze her legs together. Why?
This is crucial anatomical separation. Leg adduction is controlled by the obturator nerve, which also arises from L2, L3, L4. But the obturator nerve travels through a different opening in the pelvis, the obturator foramen, which is separate from the femoral nerve, which passes under the inguinal ligament.
A different path out of the pelvis.
A completely different path. Therefore, a trauma confined to the area just below the inguinal ligament will affect the femoral nerve bundle while sparing the obturator nerve function entirely.
Case 30 brings us back to spinal cord compression, but this time in an oncologic emergency setting. A 35-year-old woman with a history of breast cancer has back pain that progresses rapidly to bilateral leg weakness, hyperreflexia, and a positive Babinski sign.
This rapid onset in a patient with a known malignancy is classic for metastatic epidural spinal cord compression. And as you noted, this is one of the most urgent oncological emergencies. Any delay in treatment once neurological dysfunction is established risks permanent, irreversible paralysis.
The clinical signs again locate the damage for us. Hyperreflexia and a positive Babinski sign tell us precisely where the compression is happening in a general sense.
These are textbook upper motor neuron, or UMN signs. They confirm that the descending motor tracts, the corticospinal tracts, are being compressed, likely by a tumor mass growing into the epidural space. This tells us the compression is above the cauda equina, so above the lumbar region.
Right, it's not a root problem.
It's not. If it were LMN signs, flaccidity, hyperreflexia, we would suspect damage lower down in the cauda equina or a peripheral lesion.
What are the most common primary tumor sources that migrate to the spine?
The classic sources of bone metastases are the cancers that metastasize hematogenously through the blood. So we think of cancers of the breast, prostate, lung, and kidney renal cell carcinoma.
And treatment here needs to be immediate. What's the first step?
Immediate high-dose corticosteroids, typically dexamethasone. They're required to reduce the inflammatory edema and acute swelling around the compression site to buy you time. This is then followed by rapid radiation therapy or emergent surgical decompression if the spinal instability or neurological deficit warrants it.
To close out this mapping section, case 37 is ulnar neuropathy. A 14-year-old baseball player with hand weakness, numbness in the fourth and fifth fingers, and a partial claw-like hand deformity.
This is a classic occupational injury for athletes involving repetitive elbow motion ulnar neuropathy. The ulnar nerve supplies sensation to the medial two fingers, the fourth and fifth, and it controls essential intrinsic hand muscles, allowing for fine movement and gripping.
Where is this nerve most vulnerable, specifically for a pitcher?
The primary vulnerability is at the elbow, in the cubital tunnel. That's where the nerve runs superficially between the medial epicondyle and the olecranon, the area we colloquially call the funny bone. Repetitive elbow flexion and extension, which is common in pitching, causes chronic traction, swelling, and irritation in that very exposed groove.
Let's look closer at that characteristic deformity, sometimes called the Pope's blessing. What's actually happening to the muscles?
The partial claw deformity results from the specific muscles the ulnar nerve innervates. The ulnar nerve controls the small intrinsic muscles of the hand, the intraossei and the third and fourth lumbricals, which normally flex the metacarpophalangeal or MCP joints, the big knuckles.
Okay.
When the ulnar nerve is damaged, those muscles atrophy. However, the flexor muscles for the fingers that are supplied by the median nerve remain intact. This imbalance causes the fourth and fifth fingers to be permanently hyperextended at the MCP joint and flexed at the interphalangeal joints, creating that clawed appearance.
All right, section 3. Now we dive into the incredible complexity of the ocular system and the fluid dynamics that protect the brain. Starting with case 4, a student with severe eye pain and a foreign body sensation after working without safety glasses. Vision is decreased, but pupillary reflexes are intact.
The patient has a corneal abrasion, which causes intense pain and photophobia because the cornea is one of the most densely innervated tissues in the entire body. This case is an excellent way to conceptualize the protective mechanism of the corneal blink reflex.
Okay, let's trace the efferent and efferent limbs of that essential reflex. Where does the signal start and where does it go?
The efferent, or sensory limb, originates with the sensation of touch or pain on the cornea. This signal travels exclusively via the trigeminal nerve, specifically the ophthalmic branch, CNV1, to the brainstem.
Hidden.
Once received, the signal projects bilaterally to the motor nuclei of the facial nerve, CNAZ. CN uses the efferent, or motor limb, which innervates the orbicularis oculi muscle. And this causes a simultaneous or consensual blink in both eyes, even though the stimulus was only applied to one. It's a bilateral protective response.
The integrity of the fluid compartments in the eye is also essential here. Let's quickly distinguish the anterior and posterior compartments.
Sure. The eye's front space, the anterior compartment, is everything between the cornea and the lens. It's subdivided by the iris into the anterior and posterior chambers, and it is entirely filled with a watery fluid called aqueous humor.
And behind the lens?
The large space behind the lens is the posterior compartment, and that's filled with the thick, gelatinous vitreous humor, which gives the eyeball its shape.
Case 9 brings us to open-angle glaucoma. A 70-year-old patient with hypertension and high intraocular pressure, leading to progressive loss of peripheral vision and characteristic cupping of the optic disc. The silent thief of sight.
Glaucoma is the most common form of permanent vision loss globally. And open-angle glaucoma, the most prevalent type, is essentially a drainage problem. It results from elevated intraocular pressure because of an obstruction of the normal aqueous humor outflow channels, the microscopic trabecular meshwork, and the canal of Schlemm. It's like a slow-motion plumbing clog.
And the pressure damages the optic nerve head, leading to that pathological cupping and the hallmark vision loss pattern peripheral vision disappearing first. Since this is an issue of outflow, why are beta blockers, which decrease production, used. Is that just a systemic hack, or does it tell us something about the pathology?
That's a great question, and it tells us that we attack the pressure problem from both angles. While cholinergics like pilocarpine stimulate ciliary muscle contraction to physically pull the meshwork open and increase outflow, drugs like beta blockers, timolol, for example, and carbonic anhydrase inhibitors decrease the rate at which the ciliary body secretes aqueous humor into the eye.
So you turn down the faucet.
You turn down the faucet. It is a necessary hack because sometimes increasing outflow isn't enough, and we must slow down the inflow to compensate and get the pressure down.
Speaking of pilocarpine, what is that one non-ocular side effect we must be wary of?
Pilocarpine is a cholinergic agonist, and when it's absorbed systemically, it can activate M2 muscarinic receptors on cardiac muscle. This activation acts as a negative inotrope and chronotrope, meaning it can decrease both the heart rate and the force of contraction, which can be dangerous in patients with underlying cardiac issues.
Case 15 gives us the opposite kind of vision loss. Age-related macular degeneration, or ARMD. A 75-year-old patient with a gradual decline specifically in central vision, showing drusen deposits on the fundoscopic exam.
ARMD is a major cause of central vision loss in the elderly. The macula is that small central spot on the retina with the highest density of cone photoreceptors, which are necessary for fine detail, reading, and color vision. ARMD damages the central field while sparing the peripheral view, so they can see the room, but not the face of the person in front of them.
And we have two forms, dry and wet. What distinguishes them?
The dry form is the most common, about 85% of cases. It progresses slowly and is characterized by the accumulation of drusen. These are extracellular deposits of lipids and protein that accumulate under the retina.
And the wet form?
The wet form is less common, but much more rapidly progressive. It involves angiogenesis, the growth of abnormal, fragile new blood vessels, or neovascularization, into the subretinal space. These vessels leak blood and fluid, causing rapid scarring and distortion of vision, which patients often detect immediately as wavy lines when using an Amsler grid test.
Case 16 forces us into visual neuroanatomy. A 57-year-old patient with a right-sided visual defect, meaning loss of the temporal field in the right eye and the nasal field in the left eye.
This is a textbook right homonymous hemianopia, typically caused by a stroke or a TIA. This defect involves the loss of the entire right visual field, which tells us the lesion is located after the optic chiasm, affecting the left visual pathway.
Okay, so let's map the journey from the retina to the visual cortex.
All right. Light hits the retina, where the nasal retinal fibers, which carry peripheral information, and the temporal retinal fibers carrying central information converge into the optic nerve. At the optic chiasm, the nasal fibers, which carry that peripheral visual information, cross over to the opposite side of the brain. The temporal fibers stay ipsilateral, they don't cross.
And after the chiasm?
Post-chiasm, the tracks run to the lateral geniculate nucleus, or LGN, of the thalamus. It's a relay station.
From the LGN, the fibers fan out into the optic radiations, traveling through specific lobes of the brain. And this is where we can localize the quadrant defects.
This is the crucial localization step. The superior visual field information, which is carried by the inferior retinal fibers, travels to the parietal lobe in a circuit known as the Meyer loop. So a lesion affecting the parietal lobe will damage these fibers, causing an inferior quadrantinopia. We remember this as pie on the floor.
And the reverse, pie in the sky.
Exactly. The inferior visual field information carried by the superior retinal fibers travels anteriorly through the temporal lobe. A lesion here results in a superior quadrantinopia, commonly visualized as pie in the sky. All roads ultimately lead to the visual cortex, deep in the occipital lobe near the calcarine fissure, where the information is finally processed into sight.
Our final case in this section, case 13, shifts to fluid dynamics. A 1-year-old with an abnormally large, rapidly growing head circumference and a CT scan showing symmetrical dilation of the lateral and third ventricles.
This points directly to hydrocephalus. The uniform dilation suggests communicating hydrocephalus, meaning the CSF flow within the ventricular system is normal, but the issue is a failure of reabsorption.
So it's not a blockage.
Not a blockage, it's a drainage problem, often due to dysfunction of the arachnoid villi or rarely overproduction of CSF by the choroid plexus.
So let's trace the flow path. Where is CSF born, and how does it exit the ventricular system?
CSF is produced by the choroid plexus inside all 4 ventricles. It flows from the lateral ventricles through the foramina of Monro into the 3rd ventricle, then through the very narrow cerebral aqueduct into the 4th ventricle. From the fourth ventricle, it must exit into the subarachnoid space via the paired foramina of Luschka, which are lateral, and the midline foramen of Magendie.
And its fate after that, where does it all go?
It circulates around the brain and spinal cord, providing a cushion, and is finally reabsorbed back into the venous system through specialized structures called arachnoid villi or granulations, which project into the superior sagittal sinus. If that reabsorption is impaired, say, by prior infection causing scarring, the pressure builds up, causing hydrocephalus.
And the treatment is mechanical.
It is. Treatment typically involves surgically placing a shunt to divert the excess fluid, often to the peritoneal cavity in the abdomen. That's a ventriculoperitoneal, or VP, shunt.
All right, section 4. Time to examine tumors, where location is truly everything. We start with case 6, craniopharyngioma, a 10-year-old boy evaluated for short stature whose MRI revealed a calcified mass above the sella turcica, causing bitemporal hemianopsia.
Craniopharyngiomas are rare, they're typically cystic, and they are characteristically calcified masses. Their suprasellar location, right above the sella turcica where the pituitary gland is housed, immediately dictates the clinical presentation of both visual and endocrine symptoms.
This tumor has a unique embryonic origin derived from the primitive mouth lining.
It is. It's derived from the Rathke pouch, which is an embryonic invagination of the ectoderm that lines the primitive mouth, and that pouch ultimately develops into the anterior pituitary gland, the adenohypophysis. So this tumor is truly a remnant of embryological development gone awry.
Because of that very specific location, the mass causes these complex manifestations.
Absolutely. The mass often compresses the pituitary stalk or the gland itself, leading to hormone deficiencies. You get short stature from growth hormone deficiency, thyroid deficiency, adrenal insufficiency, and sometimes central diabetes insipidus.
And at the same time.
At the same time, the mass pushes up on the optic chiasm, which sits just above it. And that compression causes the classic bilateral loss of peripheral vision or bitemporal hemianopsia. It is the third most common intracranial tumor in children, though it also sees a second peak in adults later in life.
Case 10, glioblastoma multiforme, or GBM. A 52-year-old man presenting with a new tonic-clonic seizure and a persistent headache, whose MRI shows a large aggressive lesion crossing the corpus callosum.
GBM is the most common and the most aggressive primary brain tumor in adults. It's composed of highly malignant astrocytes, and its invasiveness and rapid growth are its defining features.
The histological and imaging characteristics are crucial here.
Because it's an astrocytoma, it stains positive for glial fibrillary acidic protein, or GFAP. The diagnostic histological hallmark is pseudopalisating tumor cells surrounding focal areas of necrosis.
And on the MRI.
On imaging, when the tumor invades across that central white matter connection, the corpus callosum, to involve both hemispheres, it often takes on the classic appearance of a butterfly glioma.
The natural history of this tumor is brutal.
It's extremely aggressive. Even with the best standard of care maximal surgical resection followed by aggressive radiation and chemotherapy, the median survival time is only about 12 to 15 months. The infiltrative nature of the tumor makes it just impossible to fully eradicate surgically.
Now, shifting to pediatric tumors. Case 17, medulloblastoma, a 5-year-old boy with a 2-month history of headaches, vomiting, decreased energy, and a staggering gait or ataxia.
Medulloblastoma is a highly malignant embryonic tumor, and it is the most common malignant brain tumor found in children. It frequently arises in the cerebellum. Specifically, it typically arises in the midline vermis and extends into the fourth ventricle.
The location in the cerebellum explains the gait symptoms perfectly.
It does. The cerebellum is responsible for coordination and balance. Lesions in the midline cerebellar vermis cause truncal ataxia, a staggering, unsteady gait, and difficulty maintaining posture.
And if it were in the hemispheres?
Lesions in the cerebellar hemispheres cause ipsilateral limb ataxia and reduced muscle tone. The vomiting and headaches are secondary to the tumor-blocking CSF flow out of the fourth ventricle, which leads to hydrocephalus and increased intracranial pressure.
And the microscopic hallmark.
Medulloblastomas are defined histologically by small, round, blue cells that are arranged in characteristic circular patterns called Homer-Wright rosettes, which surround an area of neutrophils. This tumor is also linked genetically to certain familial polyposis syndromes, like Turco syndrome.
The prognosis.
Despite its malignancy, aggressive multimodal treatment surgery, radiation, chemo yields high survival rates, making early detection absolutely vital.
Case 18 presents a completely different tumor profile. Meningioma. A 47-year-old woman, found incidentally after a minor car accident, shows a small, spherical, brightly enhancing lesion situated next to the falx cerebri.
Meningiomas are the most common benign primary brain tumor. They're very slow-growing and arise from the arachnoid cells that penetrate the dura mater. They're usually found along the surface of the brain, frequently in the parasagittal region, near the falx cerebri or the sylvian fissure.
Because they grow so slowly, how do they typically present? Are they always incidental?
They are often incidental findings, yes. When they do cause symptoms, it's usually subtle and slowly progressive focal neurological deficits, such as a mild focal weakness, a personality change, or seizures. These are caused by the tumor gradually pushing normal brain tissue aside. They don't invade, they displace.
What defines a meningioma histologically?
The hallmark is the presence of psammoma bodies, which are calcified concretions arranged concentrically in a distinct whorled pattern. Since they are benign and slow-growing, small asymptomatic lesions can often just be observed. Surgical resection is generally curative if the tumor is fully removed.
Our last tumor is case 20, brain metastasis. A 54-year-old woman with a known history of small cell lung cancer, now complaining of new onset nausea, vomiting, headaches, and right-sided weakness. CT shows a solitary lesion with significant surrounding edema.
Brain metastases are the most common overall cancer diagnosis in the CNS, surpassing all primary CNS tumors combined. Given her history, the metastasis from her small cell lung cancer is the most likely diagnosis.
Where do these traveling tumor cells tend to lodge, and why? Is there a specific location?
There is. Metastases have a distinct predilection for the gray-white matter junction. This is a crucial anatomical spot because the arterial vessels narrow significantly here, and it acts like a physical trap where the circulating tumor cells get lodged. They also often hit the watershed areas or the distal territories of the major cerebral arteries.
And the small cell lung cancer history should trigger us to think about associated syndromes, not just the mass itself.
Absolutely. Small cell lung cancer is notorious for causing paraneoplastic syndromes. The two most important are the syndrome of inappropriate antidiuretic hormone secretion, or SIADH, and ectopic adrenocorticotropic hormone, or ACTH syndrome.
Right.
Both of these cause profound electrolyte and metabolic disturbances that can present with nonspecific neurological symptoms like weakness and confusion, which can really complicate the overall clinical picture.
All right, section 5. This is where the immune system turns against itself, starting with case 11, Guillain-Barré syndrome, or GBS. A 27-year-old man with progressive symmetrical weakness and tingling starting in his toes and moving upward, following a recent flu-like illness. On physical exam, his reflexes are markedly decreased or absent.
GBS is a classic example of an acute inflammatory, demyelinating polyradicular neuropathy. And the hallmark is that specific ascending symmetrical muscle weakness and paralysis. And critically, you must have profound hyperflexia or areflexia. The reflexes are essentially gone because the damage is to the peripheral motor nerves.
What usually triggers this autoimmune mistake?
GBS is typically a post-infectious phenomenon. It happens 1 to 4 weeks after an infection, often a respiratory or gastrointestinal illness. The most frequently implicated bacterium is Campylobacter jejuni, which causes common gastroenteritis.
And what's the mechanism?
The body produces antibodies to fight the infection, but those antibodies mistakenly cross-react with components of the myelin sheaths on the peripheral nerves through a mechanism called molecular mimicry.
The CSF analysis provides a defining laboratory finding for GBS.
It does. The classic finding is albuminocytologic dissociation. This means there is a markedly elevated protein concentration in the CSF, sometimes very high, but the white blood cell count remains normal or only slightly elevated. This high protein, low cell count ratio is what distinguishes GBS from an infectious meningitis, which would have both high protein and a high cell count.
Given the ascending paralysis, the most critical management concern is life support, right?
Without a doubt. Because the paralysis progresses upward, it can quickly involve the diaphragm and the intercostal muscles, leading to respiratory failure. Patients must be closely monitored, often hourly, using peak flow studies to assess their respiratory reserve.
And treatment.
Treatment involves either giving intravenous immunoglobulin or IVG to neutralize the autoantibodies, or performing plasma exchange, plasmapheresis, to physically remove the antibodies from the bloodstream.
Case 23. Multiple sclerosis, or MSF. A 28-year-old woman with recurrent episodes of vision loss, weakness, and sensory deficits, with cycles of exacerbations and remissions over time. Her MRI shows multiple white matter lesions near the ventricles.
MS is a chronic, inflammatory, and demyelinating disease that is unique to the central nervous system. The risk factors include a clear female predominance, nearly 2 to 1, an onset typically between 20 and 50 years of age, and a higher prevalence in temperate climates.
The defining pathology is the distribution of the demyelination within the CNS. Where do we see these lesions?
MS is characterized by multiple demyelinating plaques, which are often visible on MRI as lesions in the paraventricular regions, near the corpus callosum and in the centrum semiovale. Since the myelin is lost, signal transmission is slowed or stopped entirely, leading to the wide variety of symptoms.
Let's look at specific symptoms when MS hits the brainstem. Those are often very high yield clinically.
Oh, absolutely. When plaques hit the medial brainstem, they can cause classic constellations of cranial nerve deficits, such as facial weakness from a CN-Deven lesion or lateral gaze paralysis from a CN-Diag lesion. Furthermore, plaques in the cerebellum or the tracts connecting to it can lead to intention tremor and profound ataxia. The recurrent, relapsing, remitting nature is really key to the diagnosis.
And what specific markers does CSF show in MS?
The CSF analysis in MS is critical for definitive diagnosis and often reveals oligoclonal bands. These are specific immunoglobulins that indicate inflammation is occurring locally within the CNS, and they're present in 85 to 95% of cases. We also often find an elevated IgG index.
Treatment for acute attacks is corticosteroids, but what about the long-term management?
Acute attacks are managed with high-dose 5D corticosteroids to reduce the acute inflammation. Long-term disease-modifying therapies, such as interferon beta, are used to try and alter the immune response, reducing the frequency of relapses and slowing overall disease progression.
Case 24, myasthenia gravis, or MG. A 25-year-old woman with difficulty chewing and swallowing, double vision, and crucially, her symptoms specifically worsen throughout the day and improve with rest.
That fatiguing, fluctuating weakness where repeated use exhausts the muscle and rest restores it is the absolute signature of myasthenia gravis. It is an autoimmune disorder typically seen in young women or older men.
What is the target of the immune attack at the neuromuscular junction? What's going wrong?
The immune system mistakenly produces autoantibodies against the acetylcholine receptors on the postsynaptic membrane of the muscle fiber. These antibodies block or destroy the receptors, leading to a reduced ability for the muscle to receive the signal from the nerve. This causes profound weakness.
And the symptoms often start in a specific place.
Yes, they often start with ocular involvement nystosis, a droopy eyelid, and diplopia, double vision before progressing to bulbar weakness, so difficulty speaking and swallowing, and proximal limb weakness.
There's an important association with a tumor of the chest cavity.
Approximately 15% of MG patients have an associated thymoma, a tumor of the thymus gland. The thymus is believed to be the site of this abnormal autoantibody production. This is why a thymectomy, the surgical removal of the thymus, can dramatically improve symptoms in up to 85% of patients, even those without an obvious tumor.
And how do we definitively confirm the diagnosis and distinguish it from other issues like a cholinergic crisis?
We use the tensilon test. This involves administering edrophonium, which is a very short-acting acetylcholinesterase inhibitor. If the patient has MG, the drug stops the breakdown of acetylcholine, resulting in a rapid, temporary surge in A-sheet concentration at the junction. This leads to an immediate, noticeable improvement in muscle strength, confirming the diagnosis.
And treatment?
Treatment usually starts with long-acting acetylcholinesterase inhibitors like pyridostigmine and can escalate to corticosteroids and other immunosuppressants.
To close out the section, case 25, neurofibromatosis type 2, or NF2. A 16-year-old boy with progressive hearing loss, tinnitus, and hyperpigmented macules on his skin. MRI shows a mass in the cerebellar region.
NF2 is an autosomal dominant neurocutaneous disorder. The defining diagnostic hallmark is the presence of bilateral acoustic neuromas, which are vestibular schwannomas. These are tumors that arise from the vestibulocochlear nerve, CN8, and they cause bilateral sensorineural hearing loss, tinnitus, and eventually deafness.
What is the genetic mechanism here?
The NF2 gene is located on chromosome 22, and it codes for a tumor suppressor protein called merlin, or schwannomin. When this gene is mutated, the protein is defective, which impairs the cell's ability to regulate its growth, leading to the formation of these characteristic nerve sheath tumors.
This case is a perfect prompt to review the two types of hearing loss, sensorineural and conductive, and how the classic tuning fork tests differentiate them.
Sure. Sensorineural hearing loss involves damage to the inner ear, so the cochlea, the auditory nerve itself, or the brain's processing centers. Conductive hearing loss is damage to the external or middle ear, the tympanic membrane, the ossicles, that prevents sound waves from efficiently reaching the inner ear.
So let's review the Weber and Wren tests to clarify this distinction to the listener.
Okay, in the Weber test, the tuning fork is placed on the midline of the head. In sensorineural loss, the sound lateralizes to the unaffected ear because the good ear hears the vibration more clearly. In conductive loss, the sound lateralizes to the affected ear because the conductive blockage eliminates ambient noise, making the sound conducted through bone easier to perceive.
And the RIN test.
For the RIN test, we compare air conduction, or AC, to bone conduction, BC. Normally, AC is greater than BC. If you have conductive loss, BC becomes greater than AC because the sound waves bypass the damaged outer or middle ear. If you have sensorineural loss, AC greater than BC is preserved, but both are diminished overall.
Section 6. Now we're focused on the acute vascular catastrophes that define emergency neurology. We start with case 29, stroke and aphasia localization. A 72-year-old woman with sudden confusion, difficulty speaking, and right-sided weakness. Her CT scan shows a large hemorrhage in the left temporal lobe.
This patient has suffered an acute stroke complicated by hemorrhage, likely involving the left middle cerebral artery, or MCA territory, given the motor and speech deficits. Her specific speech symptoms, speaking fluently, but with poor comprehension and nonsensical words, help us localize the damage precisely.
She is fluent, but she's unintelligible. It's a word salad. So where is the lesion?
That is the definition of Wernicke's aphasia, often called sensory or receptive aphasia. The lesion is located in the posterior superior temporal gyrus, which is supplied by the inferior division of the left MCA. The patient can produce speech, it's fluent, but they cannot understand language or repetition. They have poor comprehension.
And the contrast to that.
The contrast is Broca's aphasia, or motor expressive aphasia. This involves the inferior frontal gyrus, which is supplied by the superior division of the left MCA. Patients here struggle profoundly to articulate words. Their speech is non-fluent and agrammatic, but their comprehension remains intact. They know what they want to say, they just can't get it out.
We should not miss the crucial systemic clue sometimes associated with stroke. What if we see splinter hemorrhages on the nails or Roth spots on the retina?
That points strongly to infective endocarditis. Vegetations, which are clumps of clots and bacteria on the heart valves, can break off and travel as emboli, causing blockages or hemorrhages in the cerebral arteries. This reinforces the idea that the brain is always connected to systemic health, and we have to investigate the cardiac source.
Case 32. Subarachnoid hemorrhage, or SAH. A 44-year-old woman with the sudden, explosive onset of the worst headache of my life, accompanied by neck stiffness, nausea, and vomiting.
That description is almost pathognomonic for subarachnoid hemorrhage. This is bleeding into the subarachnoid space where the CSF circulates. The most common etiology for spontaneous SAH is the rupture of a Barry or saccular aneurysm in the circle of Willis.
And there's a specific spot they like to form.
They do. They're usually found at arterial bifurcations, most commonly at the junction of the anterior communicating artery and the anterior cerebral artery.
If a patient presents with a headache this bad, what is the single biggest diagnostic mistake a clinician makes before ordering the CT?
The biggest mistake is stopping the workup if the initial CT is negative in the first few hours. While CT is highly sensitive acutely, the gold standard confirmation if the CT is negative or equivocal is a lumbar puncture.
And what are you looking for in the CSF?
CSF analysis will reveal xanthochromia, a yellow discoloration of the supernatant caused by the breakdown of hemoglobin into bilirubin. This confirms that bleeding occurred prior to the spinal tap. It's definitive proof.
What is the most dangerous delayed sequela we monitor for in these patients?
Patients are highly prone to developing cerebral vasospasm, which starts around days 4 to 10 post-SAH. This artery constriction can cause delayed cerebral ischemia and subsequent infarction. Prophylaxis with the calcium channel blocker nimodipine is standard because it improves neurological outcomes by mitigating the effects of this vasospasm.
Case 33 forces us to distinguish between the two major hematomas, subdural versus epidural. A 73-year-old man who fell initially seemed lucid but progressively deteriorated with mental status changes over several days. His CT scan shows a crescent-shaped area of hemorrhage that crosses suture lines.
This is textbook subdural hematoma, or SDH. The source of bleeding is typically the bridging veins that traverse the subarachnoid space to the dura. Because it is slow, low-pressure venous bleeding, the symptoms are delayed, developing over days or even weeks.
And it's common in the elderly.
Very common in the elderly because cerebral atrophy stretches those bridging veins, making them prone to tearing even with minor trauma.
And the key imaging findings tell the story of the source. Why that crescent shape?
Because the blood accumulates under the dura, it is not constrained by the dural attachments to the skull sutures. The slow bleeding allows the blood to spread over the surface of the brain, giving it the characteristic crescent or banana peel shape that crosses suture lines.
Now let's sharply contrast this with epidural hematoma, or EDH. We're looking for the lemon slice.
EDH is a rapid, high-pressure bleed, most often caused by a skull fracture that lacerates the middle meningeal artery. Arterial bleeding is fast, often resulting in the famous lucid interval, followed by rapid deterioration.
And the shape?
Because the blood collects above the dura, it is constrained by the rigid dural attachments to the skull. Therefore, EDH appears biconcave or lens-shaped like a lemon slice, and it does not cross suture lines. Both are surgical emergencies, but the pressure and time course are dramatically different.
Our final vascular case, case 35, introduces transient ischemic attack, or TIA. A 57-year-old man with atrial fibrillation suffers sudden slurred speech and right-hand clumsiness that resolves completely within an hour.
This is a transient ischemic attack. The definition requires stroke-like symptoms that resolve within 24 hours, though typically they resolve much faster, without evidence of permanent ischemic change on imaging. A TIA is a critical warning sign. It means a permanent stroke is likely imminent.
His history of atrial fibrillation is a huge clue to the etiology.
It is. Atrial fibrillation is a prime source for cardiogenic emboli. Clots form in the turbulent, fibrillating heart chamber, break off, and travel to the cerebral circulation, causing a temporary blockage that resolves when the clot spontaneously lyses or breaks down.
Let's use his symptoms, speech difficulty and hand clumsiness, to quickly localize the likely vascular territory involved. Forget memorizing the full map. Let's use the high-yield mnemonic.
The symptoms are the map. We have 3 main arteries to track. Just remember, MCA is arms, face, and speech. The middle cerebral artery supplies the lateral cortex, including the motor and sensory strips for the upper body and the speech centers.
Okay, MCA is arms, face, speech. What about the others?
ACA is legs. The anterior cerebral artery supplies the medial cortex, responsible for the motor and sensory strip for the lower extremity. And PCA is vision. The posterior cerebral artery supplies the visual cortex and the occipital lobe.
So his deficits.
Since his deficits were speech and hand clumsiness, we know that embolism likely transiently hit the middle cerebral artery territory.
Section 7 looks at how genetic blueprinting can go wrong, often linking skin features to neurological damage. Case 22 is neurofibromatosis type 1, or NF1, a 12-year-old boy with multiple hyperpigmented macules, freckling in his armpits and groin, and specific nodules on his iris.
NS1, or von Recklinghausen disease, is a classic neurocutaneous syndrome inherited in an autosomal dominant pattern. The NF1 gene, which is a tumor suppressor gene, is located on chromosome 17.
What are the primary diagnostic criteria for NF1? What do you look for on exam?
We look for 6 or more café au lait macula. These are flat, uniformly pigmented skin patches. We look for freckling in non-sun exposed areas like axillary and inguinal freckling, multiple cutaneous neurofibromas, optic nerve gliomas, and Lisch nodules.
And Lisch nodules are those pigmented hamartomas where, exactly.
They are pigmented hamartomas found on the iris of the eye. While they're generally benign and don't affect vision, they are a key diagnostic finding. These patients are also at an increased risk for CNS tumors, specifically optic nerve gliomas and astrocytomas.
Case 41. Von Hippel-Lindau disease, or VHL. A 26-year-old man with recurrent headaches and vision changes, revealing multiple clusters of dilated blood vessels, or hemangioblastomas, in both the retina and cerebellum.
VHL disease is defined by the diffuse formation of these vascular tumors, hemangioblastomas, in the CNS, so the cerebellum, brainstem, spinal cord, and the retina. It is also inherited as an autosomal dominant trait.
Let's discuss the fascinating pathophysiology regarding the VHL protein because it's a beautiful example of molecular error.
It really is. The VHL protein is a tumor suppressor. Its normal function is to regulate a transcription factor called HIF1, or hypoxia-inducible factor 1 alpha. You can think of the VHL protein as the body's garbage man for HIF1.
Okay, a garbage man.
When the VHL gene is mutated, the garbage man is broken. This allows HIF1 to accumulate pathologically.
When the garbage man is broken, the inflammatory trash piles up and that causes the tumors.
Exactly. The accumulated HIF1 triggers the massive transcription of vascular endothelial growth factor, or VEGF, which is the most potent stimulator of new blood vessel growth. This uncontrolled neovascularization results in the formation of those characteristic, highly vascularized hemangioblastomas.
What is the biggest long-term concern for VHL patients?
Renal cell carcinoma, or RCC. The high risk of developing RCC is the leading cause of death in VHL patients. They also develop cysts in the pancreas and few chromocytomas.
Case 31, Sturge-Weber syndrome. A 14-month-old girl with new-onset seizures, right-sided weakness, and a very prominent purple-red superficial skin lesion, a port wine stain, covering her right forehead and upper eyelid.
Sturge-Weber syndrome is a rare, non-hereditary congenital disorder. It involves vascular malformations of the skin, the port wine stain, typically distributed along the first and second branches of the trigeminal nerve, CNV1 and V2, coupled with underlying leptomeningeal angiomatosis.
Which are vascular lesions on the surface of the brain.
Exactly, and the brain lesions are ipsilateral on the same side as the skin lesion, and they lead to the neurological deficits.
So the angiomas cause the weakness in the seizures?
Correct. The leptomeningeal angiomas cause focal neurological deficits like the hemiparesis and are highly epileptogenic, leading to intractable seizures. Patients often also have glaucoma and sometimes heterochromia of the iris. Treatment is symptomatic, focusing on anticonvulsants for seizure management and laser therapy for the skin lesion.
Our final case in this section is a crucial surgical complication. Case 7, recurrent laryngeal nerve damage. A 45-year-old woman complains of hoarseness after undergoing surgery for hyperthyroidism, Graves' disease.
The hoarseness is caused by damage to the recurrent laryngeal nerve, which is a branch of the vagus nerve, CNX. It innervates nearly all the intrinsic muscles of the larynx responsible for vocal cord movement. The injury often occurs during thyroid surgery when the surgeon is ligating the inferior thyroid artery, which runs intimately close to the nerve.
The course of this nerve is famously asymmetrical, and the left side has a dangerous long thoracic loop.
It does. The right recurrent laryngeal nerve loops under the right subclavian artery. But the left recurrent laryngeal nerve descends much further into the thorax, loops around the arch of the aorta, and then ascends back up to the larynx.
This long, deep course means that conditions far outside the neck can cause hoarseness.
Absolutely. Because of its lengthy path, the left recurrent laryngeal nerve is vulnerable to compression by structures in the chest like aortic aneurysms, a massive tumor in the apex of the left lung, a Pancoast tumor, or even left atrial enlargement secondary to severe heart failure or mitral regurgitation. This is why hoarseness can sometimes be the first physical sign of severe underlying thoracic pathology.
Okay, our final section. Section 8 covers metabolic, infectious, and other miscellaneous cases. Case 42 introduces Wernicke-Korsakoff syndrome, a 55-year-old man with a history of alcohol abuse showing an unsteady gait or ataxia, confusion, nystagmus, and later irreversible memory loss and confabulation.
This syndrome results from severe thiamine or vitamin B1 deficiency, overwhelmingly seen in chronic alcoholics whose diet is deficient. Wernicke encephalopathy is the acute stage, presenting as the triad of nystagmus, ataxia, and confusion.
And if Wernicke is left untreated, it progresses to the irreversible stage, Korsakoff syndrome.
Correct. Korsakoff syndrome involves profound, permanent memory loss, particularly anterograde amnesia, the inability to form new memories. And patients unconsciously engage in confabulation, fabricating vivid but false memories to fill in the gaps.
Pathologically, where is the damage?
We see degeneration primarily in the mammillary bodies and the periaqueductal gray matter. Thiamine is an essential cofactor for enzymes necessary for neuronal ATP production, and those specific areas are highly susceptible to energy failure.
The most critical treatment caution centers on the timing of thiamine and glucose.
This is a life-saving distinction. When treating an alcoholic patient, glucose repletion must always be accompanied by thiamine administration. Giving glucose alone, which is immediately metabolized, rapidly depletes the body's already limited thiamine stores. This can precipitate or severely worsen Wernicke-Korsakoff syndrome, pushing the patient into irreversible memory loss. Always give thiamine first.
Case 40. Viral meningitis. A 14-year-old boy presents with a seizure, headache, vomiting, fever, and neck stiffness after returning from summer camp. A lumbar puncture is performed.
This symptom, cluster fever, headache, stiff neck, mandates immediate investigation for meningitis. The timing, summer or fall, and the history strongly suggest viral meningitis, most commonly caused by enteroviruses like echovirus.
The lumbar puncture is essential for distinguishing viral from bacterial infection. What are the key CSF differences?
The differences are very distinct. In bacterial meningitis, the CSF glucose is severely decreased, protein is very high, and the cell count shows a polymorphonuclear leukocytosis, so predominantly neutrophils.
And viral.
In viral meningitis, the glucose level is typically normal, around 2/3 of the plasma glucose. The protein is normal or only slightly increased, and the cell count shows a lymphocytic pleocytosis, predominantly lymphocytes.
Since enteroviruses are RNA viruses, specific detection is required.
Yes, detection requires reverse transcriptase PCR, or RT-PCR, to convert the viral RNA into DNA before it can be amplified and detected. Treatment for most viral meningitis is supportive care, though we use a cyclover specifically if we suspect a herpes virus etiology.
Case 19 shifts away from the CNS to the ear. Acute otitis media, or AOM. A 10-year-old with a runny nose, ear pain, dizziness, and a bulging red tympanic membrane.
AOM is an acute infection of the middle ear. The pathogenesis involves inflammation and congestion of the eustachian tube, which connects the middle ear to the nasopharynx. When this tube is blocked, secretions cannot drain, pressure builds, and bacteria proliferate, leading to pain and the characteristic bulging of the tympanic membrane.
The middle ear houses the tiny mechanical apparatus that transmits sound.
It does, the three auditory ossicles, the malleus, incusus, and stapes. They transmit sound waves from the large surface area of the tympanic membrane to the small surface area of the oval window, amplifying the sound energy into the inner ear.
And there are muscles in there too.
Yes, the tensor tympani, which is innervated by CNV, and the stapedius, innervated by CN7. These muscles operate here, acting to dampen the ossicles in response to very loud sounds, protecting the delicate inner ear structures.
Case 27. Hyperprolactinemia. A 36-year-old woman with chronic headaches, amenorrheal loss of periods, and a milky discharge from her breasts, galactorrhea. High prolactin levels are confirmed.
This classic triad is highly suggestive of hyperprolactinemia due to a prolactinoma, which is a prolactin-secreting anterior pituitary adenoma.
Prolactin secretion is unique because it's normally regulated by inhibition rather than stimulation.
That's correct. Prolactin is tonically inhibited by dopamine, which is secreted by the hypothalamus and flows down the pituitary stalk. A tumor, even if it is non-secreting, can compress this stalk, this is called the stalk effect, which prevents inhibitory dopamine from reaching the pituitary cells, leading to runaway prolactin secretion.
The headache and visual disturbance tie directly to the tumor's location.
As the tumor grows superiorly, it compresses the optic chiasm, which sits just above the pituitary. This compression damages the crossing nasal retinal fibers, causing the classic visual field defect. Bitemporal hemianoxia, the loss of peripheral vision in both eyes.
Thankfully, prolactinomas are often treatable without surgery.
They are exquisitely sensitive to dopamine agonists, such as bromocriptine or cabergoline. These drugs act directly on the dopamine receptors on the tumor cells, suppressing prolactin secretion and often causing significant tumor shrinkage, reserving transsphenoidal surgery for only the largest, non-responsive tumors.
And our final case, case 34, syncope. A 61-year-old man with a history of chronic diarrhea and diabetes who suddenly collapsed after rising from the toilet. He denies prodromal symptoms or vertigo.
Given the context-changing position and those key comorbidities, the most likely diagnosis is orthostatic hypotension. This is a temporary loss of consciousness due to reduced cerebral blood flow caused by a failure of the body's compensatory mechanisms upon standing.
How is orthostatic hypotension defined, and why did his body fail to compensate?
It's defined by a significant drop in blood pressure, a 20 mm Hg systolic or 10 mm Hg diastolic drop upon standing. And his body failed for two reasons. First, chronic diarrhea causes volume depletion, meaning he had less blood volume to circulate.
And the diabetes.
More importantly, his diabetes mellitus caused autonomic neuropathy due to microvascular complications. This diminishes the sympathetic nervous system's compensatory response.
So let's review that normal physiological compensation mechanism that failed in him.
When you stand up, gravity pulls blood in your lower extremities, reducing venous return and cardiac output. Normally, baroreceptors immediately activate a robust sympathetic response. Your heart rate increases, and your peripheral blood vessels constrict, or vasoconstriction, to increase peripheral resistance. This action restores venous return and maintains blood pressure to the brain.
But in
this patient, the autonomic neuropathy severely blunts that crucial sympathetic vasoconstriction. This leads to a massive drop in blood pressure and subsequent syncope or fainting.
Wow, what an absolutely exhaustive journey through the nervous system. We have traversed 42 cases, from the molecular failure of protein clearance in Alzheimer's and Huntington's, through the precise anatomical maps drawn by Brown-Séquard syndrome, all the way to the moment-to-moment crisis of a vascular event.
It was an incredible deep dive, and the key insight we must carry forward is the interrelation of anatomy and pathology. The symptoms are the most sophisticated map you will ever encounter. We saw this whether we were localizing stroke deficits to the MCA territory, or distinguishing between the banana peel and lemon slice hematomas, or using the paradoxical UMMLMN signs to define ALS. Understanding where the lesion is dictates the entire diagnostic and management process.
And we hope that by slowing down and focusing on those critical conceptual breakthroughs, like the dual failure of the gas pedal and brake in Parkinson's, or the simple VHL garbage man analogy, we've provided you with a framework that makes these 42 cases feel like a cohesive, navigable whole.
And as we conclude this analysis, let's leave you with one final provocative thought that ties back to where we started. We explored many diseases defined by the accumulation of specific toxic proteins: amyloid, tau tangles, alpha-synuclein, defective Merlin. Considering the systemic nature of these proteinopathies and how some, like prion diseases, are transmissible protein misfolding errors, this raises an important question.
Go on.
Could the ultimate key to preventing most chronic neurological diseases, Alzheimer's, Parkinson's, and perhaps many others, be found not in treating the symptoms, but simply in learning how to harness the brain's innate cellular mechanisms to effectively detect, break down, and clear these abnormal misfolded compounds before they ever reach a toxic threshold? It's a question that redefines the goal of neuroscience.
Until then, stay curious and keep diving deep.